So let's start. Let me just introduce ourselves and then Dr. Kelly. I am Dr. Parijat, people from International Sports and Orthopedic Manual Therapy, ISOMT. We have Dr. Kelly Wilson here today. She's the current president of Pelvic Health Interest from American Academy of Orthopedic Manual Physical Therapy. We extend our warm welcome to her, and it's nice of her to share her knowledge and experience with all the participants here about the pelvic health. Pelvic health is a very uncommon topic to be discussed in a country like India and the other Asian countries. There are many things that we can learn as a clinician over here. Plus, the pelvic health, there are cases in whether it's a male or a female. We need to learn how to take the areas in pelvic health and know how to treat them and assess them properly. So I welcome Dr. Kelly, and then I introduce her. So Dr. Kelly, you can go from here. You can start from here. Please introduce yourself. Yeah, thanks.
Well, thank you, Dr. Kumar, and thank you, International Sports and Orthopedic Manual Physical Therapy. I'm honored to be here. It's exciting to be providing evidence-based knowledge and sharing this information with all of you. So thank you for joining me this evening, everyone. Today we're going to be talking about spinal influence on sexual dysfunction and pelvic pain diagnoses. I wanted to give everyone a little highlight, a little taste of different factors that can be involved in groin pain. For this female, we're going to be analyzing a case study. But hopefully this will be a nice preview for you guys or give you a little bit of a highlight into how much more is involved beyond just the orthopedic spectrum into, almost every patient population, whether male or female. So I'm excited to be here and sharing this information. This is a few things about me. I'm married and have 2 kids at home. I'm a full-time clinician, so I am taking care of patients 40 hours a week. I work in the central area. I also provide online curriculum to mypfm.com. And if you have anyone over, if you have any patients that would be interested in discussing online digital questions and answers, I provide those services through mypfm.com as well. So it's My Pelvic Floor Muscles. I am the president, like what Dr. Kumar said, and of the Pelvic Health Special Interest Group. And I have a blog called Pain and Simple Blog. You can go on painandsimple.blog if you're interested in I do little life hacks. It's pain hacks for people to self-treat themselves. Okay, so let's get started. So when we talk about evidence-based approach and talking about providing literature to support treatment for the pelvic floor, there is just not very much research at this point. It's evolving and it's getting stronger, but they are just now starting to get a really good base on assessment and diagnosing pelvic floor dysfunctions for the female and male population. But they still have a ways to go as far as the treatment is concerned. Certainly treatment pertaining to an osteopathic approach. So I try to share that any kind of new literature, new research that's happening, but just be aware that this is it's evolving, and anyone that is in research knows how involved it can be. It's expensive and very time consuming, but because I'm trying to do a research study right now and I'm a full-time clinician, and it's difficult at times, but I will try to bring to you the most evidence-based literature out there pertaining to this. But the current physicians that are the highest, well, at least here in the United States, that are dealing with sexual dysfunction are really leading the way as far as researching pelvic floor dysfunction and pain. The OBGYN, the physicians like Dr. Goldstein out of New York, they're really looking at the spine and how the spine is influencing pain down in the bladder, down in the uterus, down in the pelvic floor region. So there has not been a convergence of the orthopedic approach with urology, with OBGYN. You can go to the International Pelvic Pain Symposium that they have yearly, and there's no orthopedic representation at those conferences internationally, but the last year I saw 1 or 2 orthopedic doctors. There's a lot of physical therapists, but hopefully this will keep on converging. So this is a nice quote from an article pertaining to musculoskeletal causes of chronic pain. So we need to be looking at and analyzing and thinking about OA, osteoarthritis, acetabular labral tears, acetabular impingements, lumbar pathologies, and coccyx alignment as being implications for developing myofascial muscular pelvic pain. Oh, I went the wrong way. This is one study that, to touch upon, one hot topic in the pelvic floor world is discussing erectile dysfunction. PGAD stands for persistent genital arousal dysfunction. So this population has numerous orgasms, and it's a painful disorder that they have to relieve themselves from their pain by having an orgasm, and it can be upwards of every 30 minutes. So they've been really spearheading a lot of research in this direction, but what they found, the most highly correlated issue and why this is occurring is due to sacral and lumbar spine pathologies. So they're finding not only some very rare, well, Tarlov cysts aren't necessarily rare. They're actually, Tarlov cysts are little pimples. They're inflammations of the perineural sacs of the actual sacral nerve root coming out of the spine. So I think of it kind of like a pimple, so a swollen piece of the nerve root that's causing changes to the nerve root all the way down to wherever that nerve is going to. Tarlov cysts are very common, but they aren't usually symptomatic. But for pelvic pain population, they're finding that Tarlov cysts are actually a very hidden but very prevalent reason for why these people are having this pain. I will discuss later in future courses about the importance of this and the special MRIs that need to take place to find these, because they're actually more common, but a radiologist is not going to be looking for these because they think that they're so common that they're not important. Okay, but the other takeaway of the study was that it wasn't just Tarlov cysts that they're finding highly correlated with erectile dysfunction and PGAD. They're also finding that disc impingements with annular tears, facet cysts, and spinal stenosis, which is a very common thing that we see in our practice, correct? Anything along the spine can cause and make a change into the sacral nerve roots, and the sacral nerve roots are where everything, well, the majority of the pelvic floor is innervated from. So bulging disc can cause, any kind of bulging disc along the lumbar spine can cause changes to the sacral spinal nerve root. Basically, anything normal that we see can cause these abnormal pelvic pain dysfunctions. Okay, so let's move on to our case study. So this is a true patient that I had. She was a 34-year-old female, and she came into me with left groin pain. She could barely walk. She had been to numerous specialists, and she was unable to lift her leg. She was having a ton of pain. She had gotten an MRI completed, and all that was found was a mild bulging disc to L3. She had no recollection of how this occurred, how the pain happened. And her chief complaint, she had a sharp burning pain lateral to the pubic symphysis bone that radiated into her left lateral hip. She did have some pain to the low back that felt like a pulling in an ache. And she enjoyed playing racquetball for an hour, 5 to 6 times a week, but she had stopped doing that. And she was running recreationally. And she had played soccer in high school. And she remembered that she had an injury in high school where she had strained her groin her senior year, but that had resolved. So as a orthopedic physical therapist, I kind of try to pull in what are all the common diagnoses that we see within the clinic, or what we're thinking as we're hearing her tell her story. And I listed some common directions that we could go, and as we're trying to work and do our differential diagnosis within the clinic. So you would be thinking there could be a lumbar spine radiculopathy, a pubic symphysis, stress from her playing her racquetball. Rectus abdominis tear could be radiating pain into the groin area, inguinal hernia, an iliopsoas pathology. A big one would be an adductor tendinopathy, femoral nerve entrapment, hip osteoarthritis, less likely since she's so young, but something to put on the list. She could be presenting with a kidney infection, but this had also been going on for a while. But it is important to rule out an infection, especially if she had a history of that, to ask about. And then a femoral labral tear, because a tear in the hip capsule can easily radiate pain into the groin area, and around the vaginal area shares a lot of common sensory innervation with the hip joint. So that is something that can easily radiate pain into the groin region. But let's think about other possible suspects, and this is what I'm going to be talking about today. Peripheral nerve entrapment, so the upper lumbar nerves, the iliohypogastric nerve, the ilioinguinal nerve, and the genitofemoral nerve are three nerves coming out of the upper lumbar area that could be causing an issue, that could be because she's having this sharp burning pain that could be a major culprit here. I'm going to move on to the peripheral nerve entrapment topic, and then we'll go back to these other bullet points a little bit later. So this is a quick analysis of the anatomy of the iliohypogastric nerve. This nerve is mainly coming out of L1. It travels down in between the internal and external oblique muscles to above the pubic bone. It has a very direct pathway from the spine, as far as like for pain management. When they go in and do nerve blocks, they're able to specifically isolate this nerve to block. But it gets it kind of shares a lot of, not shares branches, but it shares a common pathway with the ilioinguinal nerve, which we'll talk about in a second, just to make note. But the iliohypogastric is a larger nerve compared to the ilioinguinal nerve. It shares sensory with the pubic bone, above the pubic bone. Okay, so the clinical applicability of the iliohypogastric nerve is that it's difficult to injure in isolation. So it's not going to be due to like a specific repetitive activity normally. It's mainly due to post-op. So for our patient, maybe it's purple, and then the iliohypogastric is the baby. Okay, so the ilioinguinal nerve is originating from the same as the iliohypogastric, from L1, and it travels in quadratus lumborum, and it runs underneath the iliohypogastric nerve through the transverse abdominis muscle, and so it's right anterior to the pubic bone of the ilioinguinal nerve. So it supplies the mons pubis, and it also radiates to the anterior aspect of the labia majora. But the interesting thing about this nerve is that it goes along the upper medial thigh. So like I said, the ilioinguinal nerve and the iliohypogastric nerve share common, that picture is doing a defined border, but they pretty much overlap. The only difference is the inguinal. If you have someone that has radiating pain that's radiating into the upper medial thigh, you need to be doing some differential diagnosis, thinking possibly the ilioinguinal nerve. And it supplies motor, the transverse abdominis, and the internal oblique muscles. So doing manual muscle testing to these muscles to see if there's weakness present can also help you in your diagnosis for a peripheral nerve entrapment. Like I said, it was the ilioinguinal smaller than the iliohypogastric, and this is a difficult one to injure through repetitive motion. It's usually due to abdominal surgery. It could be trauma directly to the abdominal wall as well. So someone that got punched or hit, or stressed in a certain direction, then yes, it could be an irritant to the ilioinguinal nerve. And like I said, the ilioinguinal nerve entrapment can cause weakness to the transverse abdominis and the internal obliques, and this can end up resulting into an inguinal hernia. So they're very, they're not mutually exclusive, these two. An inguinal hernia can end up resulting from a peripheral nerve entrapment, but also a hernia repair, a hernia surgery can end up further entrapping that nerve. So that's for a later discussion. So yes, I talked about the hernia surgery being bouncing back and forth and increasing the peripheral nerve pain. An ilioinguinal nerve block, I'm not sure how prevalent pain management is over in India. Over here in the United States, it's become a hot commodity with going to get nerve blocks. But sometimes it's helpful. Like this patient that came to me, she could not lift her leg up. She couldn't tolerate anything within the clinic. She was so flared up. I did work with the pain management doctor, and I actually did get him to do a specific nerve block to figure out which nerve, because it ended up being with her, the ilioinguinal nerve was the one that was on fire. I was able to get a block to help with reducing some of her pain, to go from a 10 out of 10 to get down to like a 7 out of 10 to start doing the things that I needed to do. The ilioinguinal nerve will also possibly refer pain to the clitoris. So if someone's having clitoral pain, then think possibly ilioinguinal. So last nerve, genitofemoral. This nerve it's just 100% sensory, okay? The pathway for this nerve is very undefined. The only way that you can really isolate and blocking this nerve is up in the spine. But it does run down a little bit more lateral than the ilioinguinal and iliohypogastric. It runs lateral more towards the pelvic, outside pelvic area, inside the ASIS. And it innervates along the mons pubis and the labia majora and the upper and front of your thigh. It has 2 branches. It again is commonly injured with abdominal surgeries, and this nerve can be pinched in 30% of the population. They found in a cadaver study that the genitofemoral ran direct central sensitization, that small, minute things can be aggravators for their pain. So even 1 to 2 degree variance can be an aggravator for them. So we need to learn how to be able to analyze and be a top-notch clinician, to be able to learn how to palpate properly and to be able to assess, to be able to provide correct treatment. So quickly, I know I'm running out of time, but further subjective that she reported, because I wasn't getting her back to 100%. I was getting her partially there. So I further dug in and I asked about urgency. So she was not able to make it to the restroom. She had to go to the bathroom in less than 10 minutes. She also had a heaviness, pain that increased to her left groin while she was urinating. She had painful intercourse with penetration and then severe spasming after orgasm. Her menstrual cycle was inconsistent. She had started over-the-counter birth control at age 17, but stopped after 1 year due to erratic symptoms. And they had during our care gotten an MRI that confirmed a left hip labral tear. So all urgency, pain with urination, pain with orgasm, pain during intercourse, these could all be a sign of the muscles in the pelvic floor being overactive. And so this could be a problem, and this could be a second or a primary aggravator for her continued groin pain. So the second bullet point, pelvic floor muscle overactivity. Being aware of the anatomy of the pelvic floor, which I'll discuss at a later date. There's a lot of muscles that end up originating from the pubic bone. So if you're addressing even adductor tendinopathy, groin pain, pubic symphysis dysfunction, understanding the anatomy of the pelvic floor muscles is important, since there are 3 muscles that for sure come directly from the pubic bone and share their origin site with the adductors. So If they're in a spasm state and not able to relax completely, then that's an issue. And that's also important why it's important as a clinician to know you shouldn't be just giving Kegels or pelvic floor muscle contractions to every patient, because there's a high amount of population, specifically the pelvic pain population, they're all in an overactive state. So giving a Kegel is going to basically feed them into further dysfunction. So quickly, I teach a 2-day topic over this topic, vestibulodynia. So it can cover 2 days. But vestibulodynia is pain of the vestibule. The vestibule is located inside the labia minora, where the vaginal opening is. There's the vestibule reportive of hormonal influence. So there's a lot of research now finding that there's a certain population of females that have a genetic marker that when taking birth control pills, it's causing a reduction in hormonal supply to the vestibule, causing a whole gamut of problems, causing muscle reactions to spasm, causing the muscles to become weak, causing atrophic issues at the vestibule. And so understanding the biology behind why this is happening with just common birth control pills is a very, very important in our practice to help further gain a further understanding of our patient population. Let me see. So our patient Alexis, she had 3, when I asked about infection, she had 3 positive cultured tests for UTI within the last year, and she had been treated 5 times. She had taken 5 bouts of antibiotics. So there is research out there about repetitive infections and the importance of understanding of giving. We know that giving repetitive antibiotics is not beneficial. It causes a reaction to our immune system, but specifically taking an antibiotic to treat a bacterial infection at the vagina is a major problem. There's been studies done for females that were given, well, actually it was a research study done on rats, but they were introduced to a yeast infection, and then they were treated within a certain time period. They found that after the 3rd treatment, if it was within a 3-month time period, their pain threshold stayed elevated, stayed lowered. So let me just go back for a second. When our pain threshold to be stimulated is usually at a higher level, like if you hit your hand with a hammer, it stays at this higher level. But when we become infected with a bacterial infection, our threshold lowers for a bit throughout that infection rate. That's why we get a little bit more pain. If we get prescribed an antibiotic with a true infection present, then with time, after a couple of days, our pain threshold raises back up. But if you reintroduce that infection and then give antibiotic, then it recovers. But the 3rd time, it doesn't recover. And sometimes they found in these rats it never recovered. So it's important to, 1, have a culture confirmed positive test for infections and not just be taking antibiotics for no reason, okay? And this is going to help you too understand in your practice, like if someone did take a bout of numerous antibiotics within a shortened period, they are going to be feeling more pain. That's why they're feeling this really high over the top pain level, and it'll help you a little bit better understanding the psychosocial impact for you as a clinician. Positive Q-tip test is a way that we diagnose in the pelvic floor at the vestibule. That would be a discussion greater, but if I take a Q-tip and I touch along the inside of the vaginal opening along the vestibule and do a light touch test, this test can be very telling about if this pain is being driven from a hormonal issue or from a muscular issue, and it helps me as a clinician to understand which direction and which pathway you need to go, whether it be a medical management or whether something I could address through physical therapy. And then she also had left-sided atrophy along her labia minora. So sometimes there's visual changes after these women are taking birth control pills, that they are having reabsorption of their labia back into the tissue. So it's essentially disappearing. And this is something visually that you could see. And this could be a sign that she has some hormonal imbalances. So hormones can play a big issue in pelvic pain. So understanding this is very important. This is something that I could touch upon and will, certainly touch upon for those clinicians that are interested in understanding further issues for why there is pain arising within the pelvis. Alexis ended up getting prescribed a topical estradiol. So she got prescribed estrogen and testosterone, a compounded, where she just lightly applied just a little bit of pea size around the opening of her vagina. And you know what? She ended up responding great to it because she had such a lack of hormones within her vestibular region that this was causing a ton of reason for why she was having her pain within her groin. Now, let's touch upon just real fast her MRI confirmed labral tear. Dr. Cody did a study about vulvodynia, which is pain of the vulva, the pelvic area, and concomitant of femoral acetabular impingements. And what they found was the younger population, aged 22 to 29, that had clitoral pain for less than 4 years had significant improvement after their scope to correct their labral tear. So it's just showing that there is a high correlation potentially within this younger population with symptoms that have been less with shared innervation of the labrum with the clitoris and with the pelvic floor. So with her labral tear though, I ended up just doing within the clinic hip mobilizations, addressed what I would normally do with addressing her lack of hip internal rotation, her pain with end range hip flexion. I did distraction, inferior and posterior glides, hip mobilizations, and I did a hip manipulation and improved her hip range of motion, and she had reduced pain at end range flexion. Today she's great. She's playing racquetball daily. Her pain can return at times depending on the intensity of her menstrual cycle. I need to change this bullet point. I don't see her anymore. I check in with her like every few months, but she's been really doing great. She's independent with her program. She's able to self-correct her pelvic obliquity, the orthopedic approaches that I addressed with her, she's able to do and fix at home. And she's still on her compounded topical cream. So, we need to be able to, a house can't be built without a sound foundation. So, looking at the muscles, looking at the nerves, looking at the structural components, but also be thinking about other factors like birth control pill usage, how many recent infections she's had beyond 6 weeks, asking those questions about further diagnostic imaging, and asking those questions that we aren't quite comfortable to ask. But within the clinic, I just purely ask, like, I'm asking these things about your urgency or about your sex life because the spine, and I showed them a picture of the anatomy of the spine, the upper lumbar area is a big supplier for everything down below. So these are why I'm asking this question, to give a holistic approach for your treatment. So I want to again thank, the International Sports and Orthopedic Manual Therapy Program for inviting me to do this. I hope I provided some insight, and I apologize for running through so quickly with this information. It's a lot of information within 30 minutes. I hope to share and I'm a part of this team, and to share further my knowledge and input into the realm of pelvic pain diagnoses with an evidence-based approach.
Thank you so much, Dr. Kelly. Can we take some questions here that the participants had?
Yeah.
The one question the participant had, that is there the incontinence, whether it's fecal or urinary, can be due to the pelvic torsions, and can they also be corrected through these spinal and pelvic manual therapy correctors?
So there's been there's been an evidence-based, a systematic review that has analyzed the research on, it wasn't necessarily on for incontinence, or fecal or urinary incontinence. It was more towards, it was a follow-up from that dysmenorrheic study for the patients with painful periods. They found that manipulative osteopathic approach did reduce their symptoms and help. There has not been any current studies on manipulation, on changes within leakage. Although I have to say, clinically, my practice, I sometimes don't even have to treat a patient internally or via pelvic floor. I can do 100% orthopedic approaches through manipulation of the pelvis and get resolution of their urgency or leakage.
That's good. Another question was, and this is a very basic question, and this was actually one of our main topic. A participant wanted to know commonly how the lumbar disc disease can cause a sexual dysfunction.
Well, so they're finding that these these basic findings that we're finding through imaging, an annular tear, stenosis, basically if there's any kind of hitch on the spinal nerve root, that can cause a pain down the chain. So the conus medullaris is at L1, L2. So after that, any kind of little hair, well, it's the horse hair, but like the lumbar, the spine can end up causing a certain change, and anything from L1 to below can cause issues in the sacral nerve roots and change the way that their pathway is to the muscle or wherever it's going to go. So it results in sexual dysfunction or urinary incontinence issues, pelvic pain disorders, the like. That's a very global answer. I hope I explained that.
No. Yeah, that answers. Another last question, I wouldn't be taking much of your time, was that like we have nerve tension tests for different nerves, like the upper extremity nerves and the lower extremity nerves. In order to check the groin pain, are there any nerve tension tests for iliohypogastric nerve or ilioinguinal nerve or genitofemoral nerve like that?
The most general one that I've seen is like where you take the non-symptomatic side and you elevate that foot onto a stool or a table kind of, so that side's bent, and then you can side bend towards the non-symptomatic side. So your symptomatic side, you're standing on that leg, the symptomatic leg, and then you're side bending away from that side. That is one nerve glide that you could do to test. I've also done like a femoral nerve glide as well, like laying supine with kind of like a modified Thomas test, but with the symptomatic leg hanging off. That kind of tests more saphenous nerve. But you can also, if the pain is located or isolated to the groin area, you can find out if they're having more tension along the upper medial thigh or where it is specifically the pain is occurring to help differential diagnosis. Does that answer your question?
Yeah, that does. One quick last question, Dr. Kelly, would be, and it's a very basic and assessment kind of a question, that the participant wants to know that how can they differentiate and assess at different levels that the nerves are getting affected and those are causing the pelvic floor muscle dysfunction. I mean, I guess these are the overlapping questions that has the same answer. So they wanted to know that how these nerves can be assessed at different level, which can be causing your pelvic floor muscle dysfunction.
Right. I mean, truly, I'm every time I'm assessing, I'm feeling for upper lumbar. So in my practice, I assess for segmental mobility of the lumbar spine. So I do, it's kind of like lumbar rocking. So I'm assessing the lumbar mobility from L1. I'm working up to teaching segmental mobility. I'm taking in that picture of how the lumbar spine's moving. And specifically, if they're coming to me for a pelvic issue or incontinence, it's interesting. You'll find that there's more restriction, more hypomobility at the upper lumbar. You really have to look at the whole picture with this population. I can't tell you to be like, you only should look at this for urinary incontinence, like you should only be looking here. It doesn't work that simple. And to be honest, I was just addressing in my presentation the lumbar spine, the pelvic area, but I can tell you I was even more comprehensive than that. I was looking up at the diaphragm. I was looking up in breathing patterns. There, you just have to look at a greater picture with this population. So I don't know if I answered the question clearly.
Oh, it did. It was pretty self-explanatory as well, and it was pretty quite explanatory as well. But do you give do you take care of any red flags while you are giving your participant or your patients any kind of a level exercises on these pelvic floor or something like that? Any kind of a red flag to be taken care of?
Oh, well, I mean, if they're having, I mean, the major red flags would be, are they having unusual discharge? Are they having unusual discharge after doing my exams or manipulations too? That would be a red flag. If the pain is unrelenting and unchanging, if they have elevated pain at nighttime, if I'm doing things within the clinic and I'm not changing their pain in a musculoskeletal way, then that's a red flag as well. So that's another thing too with like the hormones. So like I know if I'm in the clinic and I'm not making changes with what I'm doing, then that would be something that needs to be pushed into a medical management aspect for sure.
Hello.
Yeah.
All right. Is there a way, Dr. Kelly, that people can diagnose clinically about the pelvic floor muscle overactivity or underactivity?
Yes. I mean, one way would be, well, you take in their picture and their symptom presentation. Then clinically, if you if you are experienced or trained and be able to do an internal assessment, this is with your finger, and putting your fingers on the muscle and feeling for tenderness, heightened tone, asymmetry, comparison between the right and left side, then that would be one option. This isn't purely diagnostic, but if not trained, but you happen to have an EMG unit or a biofeedback unit, you could do external stickers along the pelvic floor and see if their tone is heightened beyond like 2 microvolts. But if it's completely excessively heightened, then that would be the way to be able to diagnose if they were having overactive muscles. But you can also palpate externally as well, and you could feel if there's asymmetry of comparison. If you have hands that can feel for changes in muscle tone, then you can palpate externally as well. Just you need to be trained on how to palpate around the pubic ramus, and then you can kind of feel if the muscles are, have increased tone or spasming.
All right, I'll let you go. I know that there are never-ending questions over here, but some of the participants asked that are there any male PTs or physical therapists in United States who are pursuing this women's health and the pelvic health thing, because they want to ask the same thing because of the social cultural factors over here, that whether a male PT can hone their skills in this pelvic health therapy and can kind of go from there because of certain differences over here. It's a good question.
Yeah, we do have men that are doing pelvic health over here, and I'm highly for my courses over here. I love it when I have men in my courses. Very welcoming. I'm excited for anyone that's interested in this topic. Now over here, there's still it's still a cultural. It's weird because the majority of physicians that do OBGYN is still a male-driven profession. Same with urology, but yet physical therapy, I guess, is thought of, at least in America, kind of for public health, like a female-driven. But we're trying to change the outlook of this and the expectations. But we do have not chaperones, but witnesses in the room if there is a male physical therapist that is doing internal work. So when we don't have those guidelines for female physical therapists, I just tell my my male mentees, like, it's all about confidence and explaining exactly why you're doing this scientifically, and why this is important to do these certain treatments or certain assessments, if it needs to be internal, and just be confident with why you're doing these things.
All right. Thank you so much, Dr. Kelly. We are much over time, and thank you for your extra time. There are many questions, but I'll take care of all the questions, and We'll forward it to you and all the participants. I'm sorry we cannot answer all those questions because of some limited time. Dr. Kelly has to go. So it was so nice of you, Dr. Kelly. We'll try to arrange some new webinars on pelvic health or some related topics next time. And we hope our participants can get some of your knowledge and expertise from here.
Thank you so much.
All right. Thank you. Take care.
Bye.
Bye. All right, participants. I hope you had learned some stuff from here from Dr. Kelly. I would be sharing you our next webinar, which would be taken by Dr. Parijat and TJ. So this is the topic of our next webinar. If you can see it on the screen, we would be doing this next Saturday, a week from now, the same time. And it's a little aggressive topic over here. If you can read the questions, that are you chasing the pain or treating the real dysfunction? So we would be doing a webinar. It's a Q&A with a practical demonstration from the experts, which is Dr. Parijat and Dr. Tejinder Singh. So this will be our next webinar on next Saturday at 6 p.m.